Okay, thanks for coming today, everyone, and thanks for everyone who's going to be watching this later. I hope you're going to get a lot out of it. Today, we're going to be talking about sleep and autism, and more specifically, what we can do as sleep specialists in that area. Just to a little bit about me and how I came to this. Really, I'm an educational psychologist by my original training. I lived and worked in the UK for a number of years, and then New Zealand, Singapore. I'm currently back in New Zealand, but I sort of bounce between New Zealand and Singapore now, which is where the places I call home and where most of my work is. So you'll see actually from my introduction slides that one of the things I've included is just to give you a sense of what autism means to me as a person who calls New Zealand home and as a person who is a psychologist. So this phrase here is what is the Maori word for autism. And I think based on where you guys are, you probably haven't heard this before, but I really like this because it really, oh, hang on, sorry. There we go. It really encapsulates a lot of kind of the values that sit behind my own beliefs about autism, I suppose. So, although, of course, as a psychologist, I am trained to look at DSM criteria and how do we diagnose and looking at it in that kind of quite clinical sense. As an educational psychologist, I've worked with schools, I've worked with communities, I've worked with families. So my background is not really clinical in that very typical sense. So this name for autism really sits very comfortable with me, and it's really about understanding the perspective of the autistic person and valuing that and making use of that in how we work together.
Can I ask a quick question? I'm not sure if it's just my screen, but I'm only able to see sort of like the middle third of your slides. I don't know if
Same.
Joan and Mariana, are you seeing the same thing or is that
No,
just me?
I'm not seeing the full thing either. I
Oh,
thought it was
Yes,
just
I
me.
was trying to figure out. Yes.
is that any different?
Oh,
No,
no,
it's
it's
bigger, but it's
bigger,
still
but
cut
it's
off on
not.
the sides.
Oh, that's
Yeah,
Thank you for bringing that up because I was struggling with that. Oh, there we go.
there it is. Thank you.
is that
And it's on the picture of you.
yeah. Can you see
Yeah.
the full slide? I see you can see
Yes, now I can.
yeah, I've got a slightly tricky setup. Is that can you see the whole slide though? Yeah, okay.
Yeah,
Great.
it's good.
Thank you.
Thank
Thanks
you.
for letting me know. Yeah, so that's just a bit of background about me and how I came to this. I started specializing full time in sleep nearly 4 years ago. But as a psychologist, I was working with people who weren't sleeping all the time. And it was one of those things that just wasn't really being addressed. So really, I was working with autistic people before I was working with sleep deprived people, but I was seeing that overlap. In terms of the work I do now, because of that background as a psychologist, a lot of the clients I work with are autistic or parents of autistic children. And I run workshops like this quite often. So it's that kind of overlap of where the broader sleep stuff meets more specific psychology or educational psychology. That's kind of my angle. Um, so what we're gonna be doing today is just I'm going to be presenting information to you based on my own experience and based on what the research is telling us at the moment. And actually, there's huge amounts of research out there. So I've summarized and I've picked out the key things that I think are going to be most relevant to you and to the discussions today. There's going to be a reading list at the end as well. So after today's session, I'm going to upload the slides, a reading list, and some resources to a page on my website that only you will have access to. And I'll send you all a link to that so you'll have access for a week. So you can download some things, you can rewatch the recording and have a look at those resources and do some extra reading if you want to. But I also want to acknowledge that I'm still on the learning journey. This is such a fascinating and complicated topic. So I'm presenting to you what I know right now. And actually, when I was putting this presentation together, I went back to the first version of this workshop that I delivered to pick some parts out, and I feel like my own knowledge and expertise has moved on a lot since then. So it's I think you're all going to be bringing expertise to the discussions today, and I'm really want people to participate as much as you feel comfortable to do, share experiences, share ideas. I know I've got my expertise that I'm bringing, but I believe that we all have that too. So very much a discussion-based session today, I'm hoping. What else do I need to tell you before we get started? I'm going to, I have examples of autistic children I've worked with that I can refer to throughout the presentation, but I would love it if you could all give me examples as well, if you feel happy to do that. Obviously, if you're going to do that, just be mindful of confidentiality within the group and people who might be watching this afterwards. So don't share any identifying features. But it'd be really useful for the group, I think, and for you individually to be able to kind of think about specific examples as we go through this today. So the agenda is pretty straightforward. I kept this quite simple. We're going to dive into this in some detail, though. So what is sleep like for autistic children and teens? How to assess that, what that means for us. And I'll share some guidelines and some examples and things from my own experience as well. And then evidence-based interventions. And I think this is an interesting one in particular around interventions because for the autistic community, there are a lot of interventions, some more useful than others, some quite wacky ones. The ones I'm going to be sharing are the ones that have some research evidence behind them. And as a psychologist, they're the ones that I recommend. And that's not to dismiss or diminish anyone's individual experiences of things that work for them. But what I'm going to talk about today is the stuff that has a robust research base. So in terms of prevalence, that's quite a broad thing, 40 to 80%. That's just because the research differs depending on how we categorize things, how we name things, research methodologies and things. But between 40 to 80% of autistic children are thought to have some kind of sleep disorder. And that compares, there's research internationally supporting those figures. And that compares to kind of between 7 to 40% in typically developing children. So significantly different. This might reflect what you've come across in practice as well. Certainly does for me. In terms of the type of sleep problems they experience, a lot of the really common ones that you'll see in other children, but just more of the same, really. So total sleep time tends to be shorter. Sleep onset latency tends to be an issue. Night awakenings, parasomnias, bedtime resistance. I'll just explain some of the acronyms. Sleep disordered breathing. Hopefully those the total sleep time and things you're familiar with. I'll use them in full as we go, just in case though. And co-occurring conditions as well. So autistic people often have epilepsy or ADHD or gastrointestinal issues as well. So all of these things can impact sleep. So these are probably things that you've come across anyway in your practice, but the thing that makes this even more complicated for autistic children is that actually there's no clear profile of autistic sleep. It can be any combination of any of those things and more. So that makes the assessment obviously a little bit more complicated, and you need to know what to look out for, but also be quite open in terms of what might come up. It's also way more variable than in typically developing children. So just in terms of night to night and as sleep develops developmentally over time. And what that means is that parents and professionals can be putting in lots of strategies, but think they're not working because the sleep is naturally changing anyway. So it can be really hard then for parents who might be struggling with lots of other things as well to persist with your recommendations because they're not necessarily seeing much progression. Some of these sleep problems are also evident from really young, so like 30 months, some of the research suggests for short sleep and trouble falling asleep. So they're evident from very young and tend to persist, but change, like sleep does for all children. You know, a teen's sleep looks different from a 7-year-old sleep, and with autistic children, that's true too. So they're persistent and they tend to be more, the sleep problems tend to persist and be more severe and more chronic, but they will also change over time as well. So again, that's something to be mindful of when we're doing assessments. So I'm just gonna stop for a moment here and say I have an example case in mind that I can give you descriptions of as we go. But I also wanted to just throw that out to the group to see if there's anyone who wanted to maybe give some examples of a child or children they've been working with who has experienced some of these things, and just give us a bit of a description.
Well, I remember having a
Okay.
case of it. Oops, sorry, someone else talking?
No, it's
Was
okay. It's
Mary?
okay. You talk, Joey.
Well, it sounds like you've worked with more autistic kids. I was just working with someone who was like, they called him on the spectrum. And I guess that I've had a handful over the years, and that's not my specialty, but again, I want to learn more. But often what tends to come up is so many like of the sensory issues, and then the weighted blankets, and I you don't have to answer it now, but that's one of the questions I have is like, what is the evidence around weighted blankets? Because I've heard so much controversy about them. So there was one period of time when I was earlier on practicing, like when I started out like 7 years ago, and that was all the rage, and that was what you would recommend. And then as time's gone on, there's a lot of mixed, information and evidence and all of that. So
Yeah, weighted blankets are a tricky topic, aren't they?
yeah. Safety wise too, I think it depending on the age too, but
Yeah, and also a lot of the families I have worked with are maybe don't have the resources to but go and buy
right.
like the official weighted blanket. You know, they're quite expensive if you get them from like an OT. If you get those yeah, so like the proper ones, I guess. Yeah, weighted blankets. I do mention them later, but I won't keep you waiting. I won't keep you hanging. Yeah, weighted blankets. There was a review of interventions for autistic or sleep and autism that was, I can't remember when, like fairly recently, though, a few years ago, and weighted blankets came under the we don't recommend these category. And that was because there wasn't really the evidence for them in terms of research. But as I said before, it's important not to discount individual experience, and also given the heterogeneity of the group, they might have really specific sensory needs where a weighted blanket could be really useful for them. So I guess part of what we'll be thinking about today is how to decide which recommendations. But in terms of something like weighted blankets, it's certainly not something that specific is not something I would be recommending to all autistic children. There might be, once you start looking into the sensory needs of a child, it might become apparent that that could be useful, in which case that's then a discussion to have. And I think the trouble is people who are struggling with sleep or other things tend to want to have a quick fix. Like, what's the thing I can go and buy that's going to help with this? So weighted blankets, I think, has kind of helped fulfill that need a little bit, but it's not necessarily fixing the issue. And they've been marketed very well, I think. So it's one of the first things people think of, but it doesn't necessarily fix the problem. Mariana, were you going to add something or?
Yes, what I've struggled the most with the families with autistic kids is the the need of presence and contact and physical contact to fall asleep. That's been very difficult to get rid of. And
Yeah.
also, I guess like the worst is the night wakings where they just sleep like 4 hours and from 2 a.m. they won't sleep again and they go all night long trying to play and being completely awake. And then they fall asleep at 9 a.m. from 9 to 12 or then that's what disturbs the most.
Yeah.
I don't know if in your experience that happens a lot.
Yeah, thank you for adding some context there. I mean, I've given you a list of the things that to look out for, but yeah, in reality, these things can be really extreme. That's certainly been similar to my experience as well, Mariana, that actually when we're talking about night wakings, they might be awake from 4 until 7. And in terms of co-sleeping, that's something that can go on for years longer than the parents want it to. And the children can be really reliant upon to get to sleep. And total sleep time as well. Yeah, I've known autistic children who seem to be only sleeping about 4 hours a night. So we'll talk a little bit about where the sleep problems come from and why those things might be happening. But yeah, for those in the group who haven't worked much with autistic children yet, these sleep issues can be really extreme. And what that means is you're dealing with really tired families as well. So your approach then needs to reflect that, I guess. We're going to talk about that too. So I'm just going to move on to what the impact of sleep is for these families. Does anyone want to throw out some suggestions? What might the impacts be for the individual child or teen? What have you noticed?
Their mood might be just really off if they're not sleeping well.
Yeah.
Like grumpy or clingy,
Tantrumy.
depending on the age.
Yeah. Yeah, absolutely, depending on the age, because this is when you mentioned clingy as well. Yeah, I mean, for a teenager, they're probably not going to be clingy, but that might look like something else. Yeah. There's a lot that goes on. I've summarized some of them here. But of course, I mean, these are the things that happen to all of us really when we're sleep deprived as well. But imagining that some autistic children might be getting only a few hours a night and that might be a chronic issue, it's way more likely to be a chronic issue for autistic children. Then the level of impact can be far more extreme as well. So in terms of cognitive skills, what the research says is all the things you'd expect really if you know about this sort of thing. So difficulties with memory, attention, executive functioning skills, mood variation, so emotional regulation, greater internalizing and externalizing behaviors. I don't you hear those phrases very often anymore, but I think they're quite useful to capture that difference between kind of the acting out versus the anxious and worried that we can see. Poor sleep in this group is linked to increased suicide ideation, suicide attempts, decreased quality of life, problems with or more difficulties with daily living skills. So those who struggle with like basic care like eating and toileting, that becomes harder. So it all gets harder basically, as you'd expect, you know, for anyone who is sleep deprived, everything gets more difficult. Interestingly, autistic characteristics become more pronounced as well when autistic children are sleep deprived. So they struggle more with social cues. They're more sensitive to sensory things in their environment, and any repetitive behaviors tend to increase as well. And we're going to come to that a little bit later as well to kind of consider why that might be. And then in terms of the family, I'm assuming, especially for those of you who are working with younger children, you'd be working with the family as well. But this is important to consider because some of these things we may or may not be able to help with, but we're going to be working with a whole family. So what's their capacity for doing the work and for implementing strategies? Parents of autistic children tend to get less sleep as well, of course, and tend to be more stressed and have less capacity to work with professionals. And they're probably already working with loads of professionals as well. So question for the group, which of these do you think has the biggest impact on sleep for children with autism? Can shout out or put it in the chat if you'd rather.
I guess anxiety.
Any other takers? I don't want to give you the answer unless other people.
Maybe parental education.
Mm-hmm. Any other guesses? It's anxiety. I mean, according to some research, of course, this is a hard thing to actually tease out, but anxiety is a major factor for autistic children and sleep. there's and it's one of the kind of mediating factors between poor sleep and the severity of autism characteristics that I just mentioned. When children are anxious, the poor sleep and the severity of autism characteristics all increases as well. So actually, that's a huge predictor of poor sleep and other difficult outcomes. The point of this slide really is also just to highlight other risk factors that you need to be aware of. So anxiety is almost certainly going to be something that comes up for you. So you need to think about ways to support families with that. But parental education, yeah, that one has been found to be connected. And that's thought to be seen as a proxy for socioeconomic status. Rather than it being directly related to parental education. So that's an interesting connection.
You know what? I wasn't even thinking of actual level of education. I was thinking like the parents' awareness of autism and sleep education in particular and like how they cope with it.
Yeah. Yeah, and because I think that would also tie in, right? Because actually, parents who have more resources, have more capacity, have more access to support and information, and probably have more effective support networks and all of those kinds of things. So, parental education is not necessarily the thing, but it represents a lot of other things that the family might be struggling with. So, not suggesting you go out and start asking your parents, like, what's the highest level of education you've achieved? Because that's going to inform my assessment. But more that getting a sense of what the family context is important here, because that does have a factor in terms of how you're going to support them and what kind of interventions you're going to recommend. Cognitive functioning hasn't really been shown to make a huge difference in terms of the likelihood of poor sleep. Some research says yes, some research says no. So that one's kind of questionable. Gender, again, not the research on that is mixed, but we also know that boys and girls sleep differently, and girls do tend to have more sleep problems and different sleep problems. So I think that's an aspect there to be looked at. Also, typically autism has been diagnosed more in boys than girls until fairly recently. So I think that landscape might start to change. And what else have we got there? Lower adaptive functioning. Again, the research is variable on that. Depending on what you read, it will say that does have an impact or doesn't have an impact. And age, as I said before, sleep changes with time. So that's actually just a really hard one to measure. In terms of prevalence rates, it's fairly steady. That 40 to 80% of prevalence of sleep disorders is fairly steady, but the type of sleep issue, it will be different depending on age. And then the last one, co-occurring conditions. Yeah, that has a huge impact. And I'll mention a few of the key ones of that a bit later on this morning today. But it's important to know what the co-occurring conditions are that are you're most likely to see and are most likely to impact sleep. That's something to look out for when you're doing an assessment. Just going to go back. So I've put a reference down the bottom of the slide here where I've mentioned those references. They'll be on a reference list at the end, and it's not an exhaustive list at all, but they are the key ones that I think are worth reading on the topics we're covering today. So not comprehensive, but good ones that kind of encapsulate a lot of the information we're covering. So key features of autism. Now, I know that there's kind of a variable level of expertise within the group on this. So comment if you feel comfortable to, but the question I have is for you is how might those key features of autism impact sleep? Does anyone have any ideas or have any experience of seeing how those key features of autism impact sleep?
Well, from what I've learned from other like webinars and courses, like sensory activities that they do through the day that might impact a lot in through the night also. In that if they when they like get restricted sensory activities, because many parents like try to stop the stereotypes in repetitive behaviors, then that might like want to burst out whenever they have to go to sleep. Is it like what you think or what you've experienced?
Yeah, it's really variable. And I mean, in terms of I'll just start with the sensory needs. The sensory needs of an autistic child is completely unique. What they need, what in terms of sensory input, to stay regulated, is a very personalized thing. And so this is something to really focus in terms of assessment and intervention planning. And I'll describe some really lovely research on this a bit later, but what you can see is either hypersensitivity or hyposensitivity. So some children with autism might be hypersensitive to certain things in their environment. And typically something I've seen is children really struggling to brush their teeth. That can feel really horrible to some autistic children and is usually a key part of a bedtime routine. So something that can get them really dysregulated and emotionally aroused is something that they're doing right before bed, potentially. And then there's those children who are hyposensitive, and that's where maybe the weighted blankets come in fact, children who need additional sensory input in order to feel calm and relaxed. And that one becomes interesting when we think about sleep hygiene advice, which is keep everything cool and dark and calm. And actually, the generic advice is to reduce a lot of sensory input at bedtime. So parents are probably going to be receiving some conflicting advice, or advice that conflicts with what they're seeing in their own child if they need additional sensory input around bedtime. So that kind of the generic advice around, put the screen away before bed. The use of screens in children with autism at bedtime is much higher than in the normal, the typically developing population, and actually it might be serving a purpose there. So it's important to understand specifically what that family needs and what that child needs in terms of sensory input. Does anyone else want to comment on any of those? Social skills and the restricted and repetitive behaviours? The other thing I would say about sensory as well is that, again, families with less resources have less control over their environments. So they might be living in, they might not be able to control the sensory environment for their child as much as they would like to. And that's something that's important to consider when you're making recommendations, of course. In terms of, I'll jump up to social skills. In terms of social skills, this one's interesting because social skills tend to deteriorate in everyone when we're sleep deprived. And of course, children with autism are often chronically sleep deprived. And it's also something they already struggle with so much. But in terms of more sleep specific stuff, we rely on entrainment through social cues and cues in our environment in order to entrain our circadian rhythm to that 24-hour cycle, to know when it's bedtime and know when it's time to wake up. So actually, this is something that autistic children struggle with anyway. And in terms of picking up on social cues, they're usually way less attuned to that than we might expect them to be. And actually, that can then have an impact on how able they are to know when it's time to go to bed. So I'm jumping ahead a little bit, but in terms of what we do about that, some of these children need a lot more cues and a lot stronger cues to help them understand their own 24-hour cycle. They're not naturally going to pick up on all those things in the environment that tell us when it's time to start feeling sleepy. And then in terms of the restricted and repetitive behaviours and routines, that's that's something that can look so different. It's so broad depending on the flavour of autism that you're working with. But often those repetitive behaviours, it might be things like just like a repetitive movement, or it could be something way more complex, like a requirement to have a very elaborate bedtime routine in order to be able to wind down. And actually those things can serve different purposes. The repetitive behaviours are interesting because more expression of repetitive behaviours tends to be linked to more severe sleep problems. So if we look at that in a simplistic way, we might say that actually poor sleep is increasing the expression of repetitive behaviors. But actually, it's more nuanced than that, because it could be, a lot of the time, those repetitive behaviors are calming. They're part of a process for autistic children. So in fact, if they're poor sleepers, those repetitive behaviors might be functional. They might be helping them to regulate and wind down for bedtime. So it's important to consider those in terms of not necessarily like a negative outcome, I suppose, and something that we need to try and work on reducing, but actually what's the purpose of that? How might it be helping? Do we need to build that into our plan, in fact? The other element that comes in here in terms of sleep is that a lot of autistic children have that need for sameness and need for predictability, which is a key feature of autism. So actually having a really established bedtime routine can be super helpful, but also that need to perform certain tasks in a certain order in itself might, if it's too rigid, can be problematic around getting to sleep and being able to wind down.
One thing I think about is some of this obviously, well, not obviously, but some of this, it's a fine line, because some of this stuff can be evident in just a typically developing toddler, for example, that all of these things, like, the routine being thrown off, or the repetitive behaviors, or the need to do things in a certain order. And then it's like, at what point does that then, at what point do you know whether it's autism or typical behavior? I guess you have to, I would assume that part of it is just how long of a period of time. I'm thinking about, like, I have a almost 5-year-old grandson, and he's definitely like growing out of some of that stuff. But you want to do one thing, you want to do it this, and if something comes out of order, when he was 3, could completely throw him, and sort of now it's calming down. But that there, some of these things are typical of typically developing kids, right?
Mm. Yeah, absolutely. And I think if we're not talking about the kind of the extreme end autism stuff, then absolutely it can, the sort of thing that you'd be really used to seeing in neurotypical children as well. And I guess the thing to consider is we were sort of chatting about this at the beginning, like, what does autism really tell us? What does it really mean? Because autistic people are all completely different. So knowing that label gives us some indication of what to look for and what they might need help with, but also it doesn't tell us what to do. It doesn't actually tell us what they need. It's like being told someone's age, or it's a detail that's useful but doesn't give you all the answers. And in terms of some of these behaviors, they are the kinds of things that are more likely to be persistent and problematic for autistic children. But also, if we try and unpick the function of them, some of them are actually purposeful and helpful. So that's why the discussion is so important. And it's never going to be a kind of simple list of, here are the problems, here are the solutions. It's understanding how all of these things connect, and which of these things seem helpful and which seem problematic. And something that's problematic to one parent might not be problematic to another parent. So that's often a question I will ask families is, how worried are you about this? Is this a problem? Co-sleeping is typically an example of that. I work with so many families who are co-sleeping and they're worried about it. But when I unpick that with them, it's the worry often comes from a we should be doing it differently place, rather than it actually being problematic for their family. So understanding the severity of it, the impact of it, how the parents are interpreting that behavior, whether they consider it an issue, that's going to be really important. And obviously that you might, as a professional, be picking up on things that the parents aren't, and see something that potentially is problematic that they haven't realized is problematic. So some honest conversations need to happen there. But also, working respectfully with families. If co-sleeping, I think, is just a good example, because it's a bit controversial, but if they're co-sleeping with their 12-year-old and they don't, that's okay for them, then that's certainly not something that I would start worrying about or trying to address. So understanding the family dynamics and what their priorities are, I think, is the important thing there. Some autistic children are always going to have quite severe, it's not quite the right word, but, repetitive behaviors that are really apparent in certain situations. And that's not necessarily a problem. I'm just going to give you, I promised I was going to give an example of someone I'd worked with, and I realized I haven't mentioned him at all yet. So I'm just going to mention him now. We're going to call him Josh, not his real name. But Josh was a child I worked with about 18 months ago, who was 5 at the time when I started working with him, and parents were struggling. So we have fairly intermittent sessions together. So we'd catch up every couple of months or something. So like a lot of families who were struggling with sleep, they were finding it hard to commit to regular sessions. So I never quite knew what was going to happen the next time I saw them, but it was nice because I saw quite a bit of progress over the time that we worked together as well, because it was quite spread out. But Josh was nonverbal, was using pictures to communicate, only just beginning to do that when we started working together. So that was a skill he was working on, was developing. He was very communicative in other ways, though. He would guide his parents to get them to do things that he wanted them to do, or fetch things for him. He didn't communicate verbally in a conversational way, but he sang a lot, which was something that the parents loved about him, but also something that kept them awake at night, because when he was awake at 3 a.m., he would sing Disney songs for a couple of hours before going back to sleep. So no one was getting very much sleep. He seemed to be hypersensitive to some things and hyposensitive to some other things, but had been working with an occupational therapist who had created a sensory diet for him. So they already had loads of good information about what his sensory needs were, but they hadn't really applied it to his sleep and to bedtime. So that's where I saw myself coming in, interpreting those recommendations around sleep. They were also struggling to follow through with the recommendations. So as a psychologist, a lot of the stuff that I do with families is about behavior change and creating habits. So we worked on I worked with them maybe in a coaching capacity, I guess, to look at how to make those changes more stick, make them more sustainable. The OT had mentioned things like compression. So actually, I think he did have a weighted blanket, or was going to get one. But that seemed to be helping him moderate his arousal levels at bedtime. And then in terms of restriction repetitive behaviors, he seemed to be showing some of those things, but fairly low key, just some kind of low level physical movements that seemed to be quite repetitive. They didn't seem to be linked to anxiety, which is a typical connection. So they seemed to be quite pleasurable to him and maybe quite soothing. But he didn't seem especially stressed out, so they were fairly low key. And he went to bed really easily and didn't seem to have much kind of rigidity about bedtime routines. So it was really the night waking that was the main concern for them when we first started working together. So here's where it starts getting a little bit technical. And actually, Mariana, you might know more about this than I do with a neurology background. But there's interesting research looking at circadian rhythms in autism. And I'm not going to go into loads of detail, but it's just to give you a sense of what the underlying mechanisms might be, where those connections are happening. But there is some genetic research that suggests that the genes that are implicated in melatonin production or receptor function are different in people with autism. So they might actually be their circadian rhythm might actually be different in a genetic sense. And what we typically see, again, the research on this is a little bit variable, but typically a proportion of children with autism have less melatonin, daytime and nighttime, and also elevated cortisol at times when it shouldn't be elevated. So in one piece of research, about a quarter of autistic children had elevated cortisol levels before bedtime. there's a bit of a chicken and egg thing there, of course, because there's certain things that we do that create or regulate melatonin and cortisol in our bodies, and autistic children typically don't follow those 24-hour schedules in the same way that the rest of us do. So things like the amount of exercise they're getting and the time that they're spending outdoors in the sunshine, all those kinds of things that can influence your circadian rhythm might be the thing that's driving this. Or potentially there is that underlying genetic component that's causing some circadian disruption or dysregulation as well. The question then that some researchers are asking is circadian function something that is intrinsically part of autism? Is that actually something that we should be considering as part of autism? I don't know, that question's still kind of open, inconclusive, really. The genetic research is really new and lacking detail at the moment, and the melatonin and serotonin and cortisol can be described for in other ways as well. Also, those results around the melatonin and cortisol have only been seen in a proportion of children with autism. So it might actually be that there's like a subset of children with autism who have this like genetic component in terms of circadian disruption, but not necessarily all of them. But that's quite technical stuff, so I don't want to go into loads of details about it, but hopefully that's given you a bit of an overview. But does anyone have any questions about that, or does that make sense? And does it seem like what you've seen when you're working with autistic children?
Nicola, can I ask a question? Sorry, I joined late.
Well, you missed the introduction, Hayley, but welcome.
Yeah, I'm so sorry. I was actually trying to get my son to bed. He's 4. So, and hopefully now my dog's going to start barking. I just wanted to ask, just on that, I haven't worked with any children who have been diagnosed with autism. My background is in social work and I work as a sleep coach, but just there are some babies that I've worked with where, you know, now kind of 2-3 years on, I hear that they're going through a, you know, autism kind of assessment where there would be kind of lots of sleep issues as younger babies. And I'm just wondering about this, and maybe would other people share their experience, you know, where some kind of ways that you're trying to help the family improve sleep, and really what the baby needs at that time is that comfort, that support. Sorry, I'm just going to let my dog out because otherwise she's not going to stop barking. So yeah, just around the circadian rhythm kind of challenges that they have. Is that evident from a very young age, or what would the research show?
Yeah, that's a tricky one, because I guess in terms of circadian rhythm, you know, that first 6 months anyway, circadian rhythm is developing. So it's not something we really start worrying about unless it's disrupted after 6 months still. I'm not sure if this was before you arrived, Kaylee, but some of the research that I shared earlier on was around the things that typically go wrong in autistic sleep, and that some of those things are evident from 30 months. So yeah, it's tricky because children's sleep, very young children's sleep, is so variable anyway. And of course, there's always that question about when do we start worrying about this, even with neurotypical children. But I guess a lot of children won't have had that diagnosis at the age that you're working with them at. There are some people who are suggesting that because of the significance of circadian disruption for autistic children, it's something that we should be considering in terms of diagnosis of autism, that it's maybe a predictive factor of a later diagnosis of autism. But I don't know. I think probably in your situation, I would be just keeping the question mark there, because actually circadian disruption can mean lots of other things as well.
Yeah.
And there are so many.
And obviously, it's not something that you're qualified to bring up with a family, you know, to even raise it when their baby is so young.
Yeah.
as well. So yeah, it's just
Yeah.
something that kind of I wonder about.
I think when you're working with kind of the pre-diagnosis age as well, that's a tricky one. When I was working in London as an ed psych, I was often the person who was the first person to have the conversation with the family that I think your child might be autistic, and I think there's a few different schools of thought on how you do that. But I think as a psychologist who may be involved in a diagnosis, I feel a certain level of responsibility to tell the family when I think things are headed in that direction. But timing is also really important. If you're working with a 2-year-old who's experiencing circadian disruption and maybe a few other indicators, do you need to have that conversation yet? Maybe not. I guess it depends on what the family need at the time as well. And I think autism is something that's just grown so big now that a lot of, like, I even have adult friends saying to me, "Do you think I'm autistic?" And because it's just so much in the so much kind of in common knowledge now that that's a thing that exists and is actually quite common. So some families are going to be more ready for that conversation than others, I guess. But I don't know, Kaylee, is there other professionals that you would be working with who would be the ones to have that conversation?
It's more that, I just wonder, are there kind of those earlier signs, when you're working with a baby in particular? I'm thinking of one family I had very recently where their baby was 10 months old. Um, and like that in the evening needed lots of comfort and just seemed to have very, very low sleep needs. Um, but co-sleeping worked best for them. But yeah, I just would wonder about that. So yeah, and I work like, obviously with kind of GDPR legislation, it's you'd have to have families' consent to speak to other professionals. Um, so yeah, I just think it's something that has been kind of on my mind with a few cases. And even kind of children I know who are now diagnosed at kind of 4.5, 5, who would have had significant kind of difficulty with sleep as a younger baby, like I'm talking kind of 8, 9, 10 months onwards. Um, so yeah.
Yeah, I think it's especially difficult when you're working in a private capacity like that. That's the transition I made. I was in the public health sector where everyone had to consent to talk to each other. And you knew who the purple was. Like, there was a team who did that diagnosis, and you knew what everyone's roles were. But when you're working solo like that, it's a different thing to navigate. I guess regardless though, it's about what timing is helpful for the family in terms of the assessment, the diagnosis, because and that depends on where they live as well. Because in some places there'll be loads of great support for getting a diagnosis or getting an assessment and any follow up, and then in other places it might not really lead to anything useful anyway. So it's worth waiting. So I think one of the things to consider would be, what are the local supports in the area that you're working, the geographical area that you're working in? Who would do the diagnosis? Who would do the assessment? So maybe being able to, when the family are ready to have that conversation, you can put them in touch with the right people and give them reassurances that there's a pathway for them to follow. But also knowing what they get from that. I worked in one London borough many, many years ago who had most London boroughs back then had an autism service, but this London borough had a social communication needs service. And all that meant was that you didn't need to have a diagnosis of autism to get support from the autism team. And so they hardly did any diagnosis in that borough because they didn't need a diagnosis in order to get the help. So I guess it's worth kind of thinking about those things as separate but overlapping. The diagnosis, how and when is it going to be helpful to do that? But also the sleep needs can be an indicator. But it's just one of the things to consider as well in terms of what the family need and what kind of support you can give them.
I know where I am in Massachusetts in the States, early intervention is big, and it's provided to families, I think, up to age 3. So it's good because, you know, it's a resource out there, and a lot of families are recommended to it, and it's like I said, it's free. And so in some cases, I've worked with early intervention teams when I'm now that I'm like sitting still for a moment and thinking about this, I've actually worked with more autistic little ones than I remember at the top of my mind. But yeah, I probably had a handful. But yeah, and it can be extremely helpful. And then like I find having, like ENT doctors, not necessarily related to autism, but there's sleep apnea and there's, all that kind of stuff. So like building, a network of professionals,
Mm.
both for children and then for parents. It's nice to have like a list of resources that you can go to for a family if needed. So yeah, I agree.
Yeah, and I think that's a good point about the early intervention, because with autism, early diagnosis and early intervention, the research is quite clear that's super helpful. With some other conditions, there are more negative outcomes that come with the diagnosis, and the time
Yeah.
of diagnosis. But autism is something to try and get in with as early as possible, generally speaking. But it does depend on the resources in the area.
Yeah, I'm based in Ireland, and this,
Hmm.
it's a huge topic at the moment because the legislation states that you should have an assessment within 6 months, but it's taking years, so it's kind of there's a lot of advocacy for increased services. So a lot of parents will go private, but unfortunately, the public supports, which is what they need, don't recognize the private assessments. So families waste a lot of money on that. So it's complex, but um, yeah, it's just it's a tricky kind of in Ireland anyway. The supports are for especially early intervention are in great need.
Uh,
So
Yeah, and I think when I worked in the public sector, my stance was very much I had to write these lengthy psychological reports when I did an assessment,
mm,
and my stance was always I will describe what the child needs, not what is available. Um,
mm,
Regardless of the resources, I have a responsibility to say I think they need
yeah.
this and this. Um,
mm,
but when you think about how public sector funding is looking, and people's increasing reliance on private support from private professionals, and how those things combine. In New Zealand, 60%, some research has recently done this, 60% of psychologists are working in private practice now. 60%. And it's the same, people are waiting for far too long for an assessment and diagnosis. So yeah, so it's potentially something that we'll see more and more of as independent sleep workers, people who maybe could have had a diagnosis and haven't yet. And I think there'll be people at different points on that journey as well. Like I work with a number of people who will say from the beginning, yeah, we're pretty sure he's got ADHD. We just haven't assessed him yet. So we kind of work within the understanding that this might be ADHD as well, which adds a different flavor to the work that you do. So I guess it
mm.
depends a lot on where the family are at in terms of readiness for the conversation, and also what the supports are available for them, and what their capacity is to access those supports. Yeah, it's tricky. I'm going to move us on though. We've got some more stuff to get through. I'm really happy to go on tangents. I'm just aware of the people who'll be watching this afterwards, who who will might end up wondering why we're chatting for ages about something really specific. But I'll just go back to this slide for one moment, which is so that I can point out that I put the sleep, the hypnogram thing along the bottom. And the reason I did that was because there is some research around sleep architecture potentially being different for autistic children. That's another one of the question mark kind of research areas. Some of the research says maybe it is, some of the research says maybe it isn't different. So an interesting one to watch, I think, but sleep stages might be something that looks a bit different in autistic children. Again, kind of a chicken and egg thing there. Their sleep is kind of weird in terms of timing, so, and circadian disruption. So that could be potentially what's causing that anyway. Okay, in terms of Josh, things that are relevant here, his sleep timings were really erratic, but also his daytime routine kept changing. He was waking up at really different times. He was exercising and going outdoors at really different times. His meal times and his bedtimes were really variable. So just the 24-hour period of routine was really really messy. So one of the things I started looking at was how to get more of a routine going throughout the day that would help create a better bed sleep routine as well. Parents, interesting, and we're going to come on to melatonin, but Josh's parents had been giving him over-the-counter melatonin intermittently when he had a bad night. And so they clearly wanted to explore that further. So I put them in touch. I'm not someone who prescribes, and where we were at the time, that was prescription. To get the good stuff, I suppose, was prescription only. I wanted them to get good advice on melatonin, so I put them in touch with a psychiatrist who could talk to them about that in a bit more detail. Okay, other things that may be implicated in sleep disturbance for autistic children are physiological issues. So autistic children tend to be less physically active, and there's probably a number of reasons for that. The research suggests that there's all sorts of kind of incidental reasons, really. They're getting involved in things like team sports can be tricky because of the social elements, the sensory discomfort of wearing a team uniform. At school, autistic children are more likely to be excluded during recess, during break time, as in like not participating in group games, or they're also more likely to be in the classroom catching up on work or preparing for the next lesson. So they just miss some of those opportunities and ways to engage in physical activity. And we know that exercise is one of the things that helps keep our circadian rhythm on track and helps keep our sleep in good shape. They also are at greater risk, as I mentioned before, for sleep disordered breathing. And there's a few reasons why that might be. There are higher rates of obesity in the autistic community. So around 30% of autistic children compared to around 23, 24% in neurotypical children. They are more likely to have hypotonia or motor apraxia. So like physical challenges that are going to make it just that little bit harder for them to engage in physical activity and make them more likely to be sedentary. So again, there's potentially something circular going on there where actually they're less likely to engage in physical activity. That's going to impact their sleep, and then their poor sleep is going to impact their ability to engage in physical activity. They're also at way higher risk of gastrointestinal issues and food sensitivities. So it's thought that close to 40, 50% of autistic children might experience these difficulties. I've certainly seen a lot of this. The kind of symptoms you might be seeing are things like chronic constipation, chronic diarrhea, abdominal pain, reflux, feeding problems for the younger ones, and food sensitivities, restricted patterns of eating as well. There's some research coming out around gut bacteria and sleep now as well, which I'm kind of still trying to get my head around, but there's a lot of potential connections there as well. So in terms of co-occurring conditions, these are things to look out for. And then in terms of psychosocial, so this is actually, this is more broadly, I'm just broadening it out to, in the general population, the overlap between sleep disorders and psychiatric disorders. Does anyone want to have a guess at what the percentage is of overlap? I'll jump in. It's around 80%. Yeah. So people with a diagnosed psychiatric condition are 80% of them are likely to have a sleep disorder as well. And that's in a neurotypical population. So if we think about the prevalence of sleep disorders and the prevalence of anxiety in particular, and also depression really in autistic children and teens, that overlap is potentially higher. I haven't found any research on that, so I don't know for sure. But the thing that we commonly see for autistic children and teens is high levels of anxiety. High levels of anxiety are then linked to increased repetitive restrictive behaviours, which is also linked to worse sleep, and greater bedtime resistance or greater trouble getting to sleep. So, of course, the way that those things are connected, we're not quite sure of, but it's unlikely that it's a simple unidirectional thing where anxiety is leading to poor sleep, is leading to repetitive behaviors. It's more likely that those things are all interconnected, and potentially that those repetitive behaviors are serving a purpose and are functional in terms of managing that anxiety. So they could be an indicator of anxiety, and something to look out for and something to monitor in terms of frequency, but also potentially useful. How does that seem to you guys here in terms of what you see in the families that you've been working with? Is this something you've come across a lot, anxiety or other mental health issues for children and teens with autism?
I would say yes. Like, I do agree that it might be as high as 80% or like maybe even more.
Yeah, it depends which research you look at. And it depends what type of sleep disorder and what type of mental health issue as well. It's much higher for some specific issues. So that's an average of all of the different conditions that might come into either of those boxes. Yeah, and I think a lot of people doing sleep work will not necessarily have expertise in mental health, which is fine so long as you know where your parameters are, and you know what the signals are, what the risk factors are, and who to refer to. You don't need to know a lot about anxiety to be able to help improve sleep, and improving sleep is going to help with anxiety. But it's worth knowing that actually more significant mental health issues are more likely in this group as well, especially when they're sleep deprived. So knowing who that support network is, who are the professionals you'd refer to, can be really helpful here. Okay, so in terms of assessment, I've just kind of summarized some information. These NICE guidelines are pretty useful. They probably don't tell you anything you wouldn't necessarily expect, I suppose, but it's good to have some guidelines to refer to. And they mention screening for sleep disorders. So some of the things that we talked about, the circadian disruption, sleep disordered breathing, some of those things are more common. A lot of those things are more common in autistic children. But screening for them can be really tricky because a lot of our screening tools are not actually validated for use with this population. They haven't been used and evaluated for autistic children. So here's a list of the ones that have got some research backing for use with autistic children. They all come with caveats, but they're screeners, so none of them are diagnostic. None of them are going to tell you everything that you need to know. They're screening tools. But these are the ones that are probably the best ones that you can use if you want some kind of questionnaire or checklist. The Children's Sleep Habits Questionnaire is one of the most broadly used ones in terms of research with autistic children. There are autism-specific norms available. What's been found with that one is that the cutoff points is usually if you get a score of more than 41 on this scale, it's something to follow up on, but it's been found that this tends to overestimate sleep problems. So actually a higher cutoff score for the Children's Sleep Habits Questionnaire is useful. So looking more at if they score 45 or 46 upwards. That would be comparable to a score of 41 plus for a neurotypical child. The sleep disturbance scale for children, again, good screener, good for identifying kind of broad categories of issues, but not so much on the details. It doesn't screen for specific disorders, so keeping an eye out for things like snoring in case of sleep disordered breathing. The kind of more classically diagnosable sleep disorders, it's not going to tell you anything about those, so you need to bear that in mind if you're going to use this one. Then the next one, composite sleep disturbance index. This is not one I have used very much, but it was developed with neurodevelopmental conditions in mind, so has been somewhat tailored for that group. It's good for assessing the severity of sleep disturbance and response to intervention, but it's less comprehensive than the other two. So less detailed, but potentially more useful for this specific group for autistic children. It's very insomnia focused, so it's looking really at insomnia characteristics more than anything else. So again, you need to ask extra questions about other things like specific other sleep disorders. And the pediatric insomnia rating scale, it's got quite a narrow age range. It's for 2 to 10-year-olds, and is specifically looking at difficulties falling and staying asleep. It also doesn't look at other sleep disorders that you might need to get a diagnosis of later on, but it has been specifically developed for autistic children. So it gets top marks for that. So you see that none of these are going to be the only thing you'll ever want to use. None of them are the solution, but they all can be helpful if you are using them with those caveats in mind. The NICE guidelines recommend sleep diaries as well, our old friend, super helpful because there's no kind of cut-off points to that. There's no criteria. They're really helpful for identifying routines and habits and change over time. So sleep diaries, you're able to personalize it so much that it's really useful for this group. The picture on this screen is a worksheet or a tool that I have put together that I'm going to put onto the website to so that you can all download later. But basically, what I've created is this is part 1, and part 2 comes later today. But part 1 is just identifying what the key issues are. So based on what we've talked about so far, really, the tick boxes at the top are what are the main things that we're worried about, like what are the presenting problems? Is it sleep duration? Is it the amount of time it takes to fall asleep? You know, you can kind of tick the categories. It helps as just a bit of a checklist. And then what are the contributing factors is the next question. And so that's really starting to get you thinking about what are the things I'm actually going to target. If we're just looking at sleep duration, there's loads of different things that you could do to try and increase sleep duration. But if you're looking at contributing factors and whether that's an emotional issue, emotional regulation issue, whether it's to do with the bedroom environment or, you know, whatever the contributing factor is going to change how you intervene or what strategies you recommend. So there's kind of a stage 1 and a stage 2 for that intervention planning tool. So these are the 5 things that I have chosen to talk about today that have a good evidence base for children with autism. There are things like weighted blankets we're not really discussing because there isn't a strong evidence base for them. But hopefully what you'll see from the discussions today is that actually this group of people are so diverse and different that some really specific interventions are going to help some people. They might not be on this list, but if you're working with a family who are already using a weighted blanket and it's really helpful, just because it hasn't got a huge research base, if they think it's working, then it's probably helping. So we're not going to go through stuff today that hasn't got the research base, but that's not to discount it completely. So sleep hygiene. Oh, I didn't realize I'd put that animation on. I don't know why that's that quote showed up secondary. This is one of the lovely bits of research I've come across fairly recently in terms of autism and sleep. Pavlopoulou in 2021. They did they basically elicited information from autistic teens by getting them to do like photo diaries. They gave them cameras and sent them off to take photos of things that helped them sleep. And they got quotes from some people and they got them to tell stories. So these are mostly teenagers, like older children and teenagers, but there's some really lovely quotes that illustrate nicely some of the points that I wanted to make. So in terms of sleep hygiene, this first one, videos on YouTube help me relax. This is really just to challenge some of those assumptions about typical sleep hygiene advice. It's a good starting point for lots of people, including children with autism, but actually some of the nuance that we've talked about today hopefully will help you to see where you need to make some adaptations. So actually watching a video on YouTube helps an autistic child get to sleep because they're less worried, they're less likely to ruminate, they're less likely to feel anxiety before they fall asleep, then that's helpful. It might not be the best strategy or the only strategy, but if it's working, then that's part of their toolkit at the moment. So that's really important to understand from the child and young person's perspectives what is helpful. They might not necessarily know or be able to be honest with you or themselves about that, so you have to challenge it a little bit. But actually, this is true for a lot of people, a lot of non-autistic adults as well, I think. I watch TV before bed. And the other example I've given is the biking. I'm good at biking. I've noticed I sleep better on days I've enjoyed time on my bike. And of course, that does tie into sleep hygiene advice about getting exercise during the day and being outdoors. But the reason I put that on there was to highlight that actually looking at a whole 24-hour schedule in terms of emotional regulation and sleep is really important for this group. So what they're doing during the day that will probably have some positive effects in terms of the exercise, but also this movement, this activity is helping that young person to emotionally regulate and sleep better at night. So considering those daytime activities is really important too. In general, this researcher talks really beautifully about sensory autonomy at nighttime as well. So developing routines and strategies that are led as much as possible by the autistic child. So shifting from a generalized approach to sleep hygiene to more autism specific and more individual personalized sleep hygiene practices. Chronotherapeutic approaches I put on here next because we talked about circadian rhythm and potential underlying mechanisms that are maintaining those difficulties and those differences. So these are typically the kinds of things that will help or that are recommended in terms of chronotherapeutic work and helping with circadian rhythm alignment. So we talked before about circadian entrainment and that actually autistic children may be less likely to recognize those environmental cues that help us know when it's time to feel sleepy. So if you've worked with autistic children already, you're probably really familiar with things like visual timetables and social stories, but those kinds of strategies that help make routines more established and help the world feel more predictable for these children, they can be really helpful in terms of circadian entrainment as well. So things like a visual routine that helps set up bedtime, which might be a series of photos that show dinner time, shower, reading a book, getting into bed, listening to some music, falling asleep, for example, and just really reinforcing those routines to help make them as explicit as possible to these children, because they might just not be picking up on the cues as it might not be naturally picking up on those cues without some additional help. I've put light diet on here. That's kind of what I like to call it, but really thinking about intake of daylight, intake of light. We talked about screens a little bit and screens before bed. Blue light is not, I don't know how much you guys know about this, but the research on blue light it's very misleading what we see in the media. It's not the demon that it's made out to be. There are some people who are more some people who are more resistant to blue light than others, and some who are more sensitive. So that's important to consider. But actually, screens and lights for children with autism before bed might be a helpful thing, because it might be managing the anxiety. So you're weighing up the different, the pros and cons of various different things there. But also using light to strengthen that circadian rhythm throughout the day is probably more easy than thinking about taking the screen away at night, if that's what's going on for that family. So getting outdoors into daylight, which is, typical advice for everyone, might be more complicated for a family with an autistic child, because their routines are often way more complicated and way more challenging. So thinking about the best way that they can do that. The kind of the minimum thing is that they can achieve and sustain, working with them to figure that out. Bright light therapy is something that's also been used with this group. So I'm not sure if that's something that people in this group would be doing. I tend to refer that to somebody else at the moment, but that is something that can be helpful. So if you think that circadian rhythm issues are really significant for the child that you're working with, it would be useful to know who in your community could provide that kind of support. But failing that, there are bright light boxes available online, and getting a blast of bright light first thing in the morning is something that is achievable. You've just got to figure out how to make it work for that family. And then melatonin. I could talk about this for a long time, but I'm just going to, we're coming towards the end. So I'm just going to give you a summary of the research so far, which is largely to say that melatonin can be really helpful for children with autism. It can help with sleep onset, total sleep time, bedtime resistance, actually been seen to reduce co-sleeping as well. So it's probably various reasons why that happens. There's not loads of research on melatonin, long-term melatonin use for children. So that's something that I think we have a responsibility to let families know. I have a lot of conversations with families about melatonin use for their children, and there's a lot of emotional things wrapped up in that for them. So giving them the facts so they can make good decisions, I think is really helpful here. I'm not a prescriber. I don't recommend melatonin, but I might recommend that they investigate it further, or that they go and talk to a prescriber about it if you're in a country where it's prescription only. There's research that suggests that there's this kind of stuff you can buy online is really of variable quality, variable content in terms of the amount of melatonin and other things that might be in it. And I meet a lot of families who are buying melatonin online because they can't get it from their doctor. So I think it's worth giving them some warnings around that. Can be useful, but it's always going to be best if it's being prescribed by someone who knows about melatonin and can give them advice on how to take it, when to take it, how much to take, and that they get pharmaceutical grade stuff so they know exactly what's in it. Yeah, that's obviously a challenge. I mean, here in New Zealand, there's been a lot of discussions recently about increasing access to melatonin. And while I think that could be a good thing, it's also, I don't think people here know enough about it to take it, to use it well, unfortunately. Oh, sorry, Lisa. So I'm trying to keep things concise on the slides. SOL is sleep onset latency, so how long it takes to fall asleep. And TST is total sleep time. Okay, I'm speeding up a little bit because we're coming close to the end. We might run over a little bit. I just want to highlight some of the behavioral approaches. So this, I think, is probably the kind of stuff that you guys are tending to use, especially with younger children. Behavioral approaches to sleep management can be really helpful. In terms of autistic children in particular, this is what the research is saying about these approaches at the moment. They are most useful if they are looking at the function of the behavior. So when you're assessing sleep and you're seeing various behaviors that that the family consider problematic or you think might be problematic, what's the function of the behavior? An intervention that targets the function of the behavior rather than the actual behavior itself is going to be way more effective. So, for example, bedtime resistance, that could be to do with hyperarousal at bedtime, or it could be to do with separation anxiety. So if you figure out which one of those two things it's most likely to be, that's the thing you're targeting. Your intervention is going to be way more effective. Also, those interventions that focus on developing adaptive behaviors rather than extinguishing unwanted behaviors are going to be more helpful, or the ones that do both at the same time. So some of those more traditional approaches, like the extinction approaches, where you're trying to get rid of the unwanted behaviors, that alone is not necessarily helping develop any new skills. So if you're going to use those approaches, what are you going to do to help to make sure that that child has some kind of replacement skills? Also, as we've seen, sleep problems for children with autism, for autistic children, are they're multi-dimensional. So it's unlikely that one approach is going to fix everything. So you're probably going to want to look at using a combination of things, maybe a combination of behavioral approaches, maybe a behavioral approach plus some of the other things that we've talked about. Kind of got these animations coming in. I didn't think that was going to happen, but there it is. So the mechanisms by which these approaches work. I don't know if you already know these, because I think you probably use a lot of these approaches anyway. But broadly speaking, these are the kind of mechanisms that those behavioral approaches use. So stimulus control is strengthening that bed-sleep connection. So providing more sleep cues to elicit the behavior of going to bed and going to sleep, which is something that we've said already is something that autistic children often need more of. Conditioning and reinforcement, so behavior strengthening or weakening a behavior because of the consequences. Again, if a behavior is driven by something like anxiety, then this is not necessarily going to be the thing that helps. But if it's actually more of a habit, a behavioral habit, then this kind of approach is going to be useful. And then exposure and habituation is the other kind of key thing that tends to come in here. So if you think about like the chair method, where co-sleeping, the parent is gradually moving further and further away from the child's bed. That gradual exposure to a situation that makes them feel emotionally aroused, so that their emotional response starts to dampen over time. So typically they're the mechanisms that are useful for autistic children when we're going to use behavioral approaches. And these are the specific approaches that there's been research done on, and the research says can be useful for them. So bedtime fading, sleep scheduling, and positive routines. I'm not going to explain those because there's no time to go into that level of detail today, but these are the ones to go and look up if you're not already using them and you want to get more skilled up in behavioral approaches to sleep management for autistic children. They're the ones where the evidence is at the moment.
I have a quick question. Going back up to conditioning and reinforcement, would reinforcement be like some sort of like positive praise whenever they, follow the bedtime routine? And when would you give that praise? Like at the moment or in the morning or in the middle of the night if they, are following what you want them to do?
Yeah, it depends on so many different things, I think. Yeah, that's a perfect example. Positive reinforcement can be whatever is positively reinforcing for that child. Even for myself, I quite like to receive praise. I also like to be given cake. So that would be positively reinforcing for me. And whether I want that praise or that cake immediately, or whether I want to know I'm going to get it tomorrow, that depends. That's variable as well. So that's a great example in terms of a template for something you'd work on, and then you'd want to work with the family and the child to figure out how's this going to work for you. What's going to be the most motivating thing for you? Like so many kids like sticker charts, or they might be a real like a toy they want to work towards, or snacks, or and when we're talking about those rewards and reinforcements, especially for autistic children, I guess having something very tangible initially can be very helpful. And frequent rewards and quick rewards is where you start with behavior management. And then as that behavior starts to get intrinsically more rewarding in itself, you can reduce the frequency of the rewards, reduce the size of the rewards over time. So it's something that you would vary and play around with. Okay, I see that we're basically out of time. For those that, if anyone needs to go, this is being recorded and it's going on my website, which I'll get a link to today or tomorrow, depending where you are. But if you can stick around, we are quite close to the end, so stay if you can. CBTI is the next one on the list. Is there anyone in the group here who would be using CBTI?
I was trained to use CBTI. I haven't done a heck of a lot of it, honestly. I think it's fantastic.
Yeah, me too. I love it.
Yeah, I'm actually due to start the training in November in the UK.
Oh.
Oh, brilliant. Yeah, it's I love it. As a psychologist, it just makes so much sense to me.
Yeah.
I love this model. It's so practical, it's so pragmatic. I use it with a lot of adults actually, but it's a great approach for insomnia. And there are components to CBTI that you would use even if you're not doing full CBTI. You can see from that list of what it includes that a lot of that stuff would actually be helpful for this group anyway. So psychoeducation can be really helpful for older children, teens, parents, because there's a lot of assumptions about autistic sleep that are inaccurate, that it's inevitably going to be bad, that intrinsically autistic children will have poor sleep and there's nothing they can do about it. So actually the psychoeducation element, so that people can have a more realistic set of expectations around sleep, that's real helpful. Covers sleep hygiene, which we talked about before. So this would look slightly different for autistic children. Adapted sleep hygiene, basically. It covers stimulus control therapy, so that bed equals sleep stuff, and looking at sleep retiming or rescheduling. Traditionally called sleep restriction. I don't like to use that phrase, especially for people who are not getting enough sleep. So, but looking at sleep timing to kind of increase sleep drive and increase sleep timing regularity, which of course is a major factor for autistic children. Cognitive therapy is the bit where you're looking at beliefs and attitudes around sleep and which beliefs and attitudes people might have that are unhelpful and would be maintaining those sleep problems, like things like, I'm a terrible sleeper, I'm never going to sleep again, I'm going to die young because I sleep horribly. Challenging some of those thoughts that are actually creating more problems than solutions. And relaxation training. And of course, children with autism, increased levels of anxiety in that group, which are keeping them up, stopping them from falling asleep. So CBTI can potentially be really helpful for autistic children. There can be accessibility issues, of course. This needs to be adapted, needs to be developmentally appropriate, and it might actually be the family, the parents that you're working with, rather than the child themselves. But yeah, can be super helpful. I'm really pleased to hear that there are people in the group doing it or going to be doing it. I love it. It's very practical, so it's therapeutic, but not in a traditional talking therapy kind of way. So I think that makes it much more accessible for families who are worried that we're going to have to delve into all sorts of really personal things. But it shows good improvements for children with autism: sleep onset latency, night awakenings, total sleep time. And those improvements there's research saying up to 6 months, but potentially beyond. CBTI in other populations tends to have much longer lasting effects. So probably for this group too. Again, this is something that we could go into way more detail than we have time for today. So it's really just to highlight that this is an approach that you can work with this group, that you can use with this group. And so if you want to think about how you would adapt it, how you would tailor CBTI for the particular family that you're working with. Another missing quote. I don't know how that's happened. So this is again that research that was the photo story elicitation one, Pavlopoulou. So looking at arousal regulation, and this ties in really largely to the sensory issues, because that's one of the main things: sensory issues and anxiety that are creating a lot of the problems for autistic children as they try and sleep. And the examples here are just some typical things, really, that, again, it's just some of the sleep hygiene, generic sleep hygiene advice will go against some of these things that might actually be helpful for these children. So it's worth challenging some of the traditional advice to see what's genuinely useful for them. The breathing exercise, obviously a classic, that first example. The second one, drumming. I'm only allowed to have a short session before bed. It feels relaxing after. I mean, I wouldn't want to be his parents, but 15 minutes of drumming really helps this kid fall asleep just before he goes to bed. And that's not the kind of advice you would typically be giving. So this is the kind of thing that you find out if you ask the right questions when you're talking to the child and the family. And then the third quote I put on there is just to highlight that actually the stuff that happens in the day really helps with arousal regulation at night as well. So this young person gave a lovely example of, I know that I'm going to see Mr. X on a Wednesday, so on Tuesday night I'm thinking about a joke I want to tell him. And that's helping to minimize the risk of rumination and catastrophizing while they're trying to fall asleep. They're thinking about something positive instead. And they know is that predictability and the routines of what's going to happen tomorrow. They know what's coming. They know there's going to be positive experiences in school. So these kinds of details are really lovely to discuss with children and their families to figure out exactly what it is. Like you just might not have realized or guessed that that would be the thing that would be helping this child to sleep unless you have a really rich conversation with them about it. Okay, really close to the end now. 8 minutes over already. So these are my top tips for intervention. Personalize, get creative. Yeah, this group, autistic people are all very, very different, as we've said throughout. So, and also the generic sleep advice that works for most people might need to be quite significantly tailored for them. So don't be worried about going off piste and just going with the family on what they think might be working, unless it seems really wacky and wild. Be ready to get creative and think about solutions that you might not come up with for other children. Focusing in on needs, not symptoms. So like I said before, it's way more helpful to think about what's the cause of this issue. If they're not getting enough sleep, why are they not getting enough sleep? There are lots of reasons for this group in particular why that might be happening. And hopefully some of the stuff we've covered today will help you to know which questions to ask and what direction you might go in terms of understanding what those problems are, so that you're focusing on fixing the problem rather than the thing that's presenting immediately to you. Take a multi-component approach. Yeah, like I said at the start, autistic sleep is not a single profile of things. Unfortunately, it's way more complicated, but also then way more interesting than that. So be ready to use lots of different strategies at the same time and try and address a range of things in a range of ways. It tends to be way more effective. Think about the family. How are you working with the family? They know their child and their family best. I'm sure you are already doing these things, but I think this is especially important for these families because they have quite unique needs, and there are needs that often get overlooked. Children with autism often have a lot of other professionals working with them on other things. Not many people are talking to them about sleep, and if they are, it's kind of seen as well, that's just how it's going to be. So helping them understand that this is a really important piece of work and that they are crucial in terms of figuring out the strategies and maintaining those strategies. Thinking about intervention fidelity. Typically, parents of children with autism are going to have more trouble seeing things through because their lives can be pretty hectic and chaotic. So thinking about the interventions and strategies you suggest, you need to consider how realistic they are for the family and discuss that explicitly. Do they believe that this is going to help? Because maybe the work you need to do is helping them believe it before actually giving them things to do. So figuring out where they are and being part of the team with them. And then also knowing when to refer. So we talked about things like gastrointestinal issues, sleep disordered breathing. So there are some physical things. There might be some mental health things that you're looking out for as well. Knowing like what your capacity for that is, where your boundaries are in terms of what you can help with, and where you refer those children to if you see a risk factor that you can't deal with. And then I just wanted to share the second part of the intervention plan. This is going to be on the website after today. So if you remember, the first part was really about identifying what the key issues were and what the contributing factors were. So you get a sense of what you're going to focus on, what your priorities are for intervention. For part two, we've basically filled in a lot of this already with the key things that come up for this group. So a key area, you pick the point of the worksheet, the checklist is you pick the things that you're going to focus on. So maybe you're going for sensory autonomy, supporting sensory comfort and regulation. Maybe you've highlighted from part one of this checklist that's one of the main issues you want to work on. I've given you some example strategies there that is based on the research that we've talked about today and other research I've covered. So some examples, but again, like weighted blankets could be on there for this family. It's not on there because there's not the research behind it. But if you have a conversation with the family and they say, oh, we think this might really help, then your plan and personalized box, you put weighted blankets or whatever adaptation or strategy you come up with that's going to work for them. So that first column is the key areas for intervention that covers everything that we've talked about today. There's also on page 2 of that, there are some blank spaces. So not assuming that I know everything about the family that you're working with here. There are blank spaces for you to fill in other areas for intervention and other strategies that you might come up with the family. And that's it really. So we're just to summarize, what are you going to do next? Is there anything that you want to find out more about? Is there a screening tool that you want to try from those ones we mentioned before? Are there any intervention strategies that we went through that you think you'll have a go at or you want to know more about? Feel free to put something in the chat or call out, unmute if you want to make a suggestion about what you're going to do next. I usually end with this because it's helpful for people to say these things out loud to other people. You can go to a workshop and then do nothing differently afterwards, but you're way more likely, the research tells us you're way more likely to follow up on something if you've told someone else you're going to do it. So if any of you think, oh, maybe I'd like to try that, but you're worried you might not see it through, say it out loud now, tell the group. No, nobody wants to commit.
Well, it's hard too because we need to have this population in our practice too. So it would be a matter of one way to commit, I guess. I'm not sure I'm ready to, but it's, to put the word out to people that you're doing some work with autistic children. And
Yeah.
then if you have this population, then it's easier to sort of say you're going to try it or do it.
Yeah, I agree. I think
So,
it's a great one. Yeah.
I mean, it's appealing to do the work because, you can really be helpful to families,
Yeah.
to a wider range of families, I guess.
Yeah. And to families who aren't getting that specific support, it feels to me as though there are quite a lot of people who know about autism and there are quite a lot of people who know about sleep, but there are very few people who know about both of those things together.
Yeah. Mm-hmm.
You can't just translate sleep knowledge to autistic children because, as we've talked about
Right.
today, it's quite they have some quite unique needs and specific things that will work for them. So you guys are very important. Go out and do the work.
Yeah.
I think for me, I was just going to say I need a little more, and I need to focus more on my population, which would be like preschoolers, because that's typically who I work with,
Yeah.
um, and kind of, research some more things that will apply to them specifically. Although there is a lot of overlap between like
Yeah.
neurotypical, like sleep hygiene, the sleep routine, like there's so much that is, but I find what parents are asking is like, well, are you trained in working with autistic children?
Right.
And it's like, Well, no, I'm not yet, but I'm gathering certifications or, there is no one certification that I know of. It's just kind of like keep taking courses and webinars until I feel comfortable. So
Yeah,
that's kind
exactly.
of my next step. Yeah.
Yeah. Yeah, and I think yeah, it's a tricky thing. I mean, even with sleep more broadly, right? There's no clear qualifications. There are courses you can do, but um, we probably all have completely different training behind us when it comes to the sleep work we do. Um, I think some when I'm working with autistic families with autistic children or with other conditions that I don't know very much about, I guess my goal is humility and curiosity. I think quite carefully about what I do and don't know, where the boundaries of my knowledge are, but also if you go with that approach, then you've still got something to offer. And if you consider the family as part of a team that you're all in together, um, that can make it feel less scary as well when you feel like you don't know what you're doing.
Right.
Okay, we should probably end there because we run. Thanks for sticking around. We had some great discussions, and I'm sorry we had
Thank
to speed
you.
it up towards the end. But if you want to know more, this is going to all go on the link anyway. But yeah, there are other resources on my website and other workshops that I run periodically. So keep an eye on those if you enjoyed this and want to know about some other topics. The QR code is just a link to the website. But the stuff from today is not going to go on the main website. It's going to be on a page specifically for this workshop. So I will send you the link to that after we finish, and then you'll have a week to view and download all the things that you want to view and download. And thank you so much for coming, and thanks for the conversations. I love running these kinds of groups because it's always so interesting for me too. I hope you've enjoyed it, and please feel free to email me afterwards with any follow-up questions or feedback, or if you just want to stay in touch about sleep-related things. I love these kinds of conversations. I'm always happy to chat about it.
Thank you so much.
Thank
Thank you.
you. I really enjoyed it.
Oh,
Yeah,
good.
me
Thank
too.
you. I'm glad. I did too.
Take care.
Okay. See you guys.
Bye. Oops.